Alright everyone, let's talk about the general structure or the master key structure. That will be the structure that we use in every single case, and any other changes will be driven or will be actually reflecting to the general structure all the time. So any case in Lab 2, you will have a patient coming with a problem which we call presenting complaint. Okay, that can be a symptom, can be a problem, can be maybe a follow-up, but he has been getting symptoms before that follow-up. So always we'll end up having a presenting issue, presenting complaint. Okay, so what we do, we start by exploring the presenting complaint. So the first step is exploring the presenting story, and we explore it by open question. What is the meaning of open question? That is open-ended question, such as, for example, tell me more about that. So that's an open question for the patient to give me a full story. So listen to the patient carefully, start with an open question, because that is what we call the golden minute in the consultation. That is when you can reach the right diagnosis by listening to the perfect story of that patient here. So Mr. Jack, can you please tell me more about that headache? Listen and listen carefully about that. So once you finish that step of open question to listen to the golden minute, then you can still explore presenting complaint by completing what is missing from Socrates or Udibara. Socrates for pain or headaches, Udibara for any other symptoms here. You still have another category of symptoms such as event-like symptoms like fit, for example, or fall or dizziness. These kind of symptoms I call like an event. You can explore them by beforeing, during, after, but now focus on Socrates and Udibara. If you have a pain symptom such as a chest pain or headache, then ask an open question, listen to the golden minute, and then complete what he didn't mention from Socrates. For example, when did that start? Is it getting better? Anything is making it worse? Okay, how strong is that from 1 to 10? Where exactly is that pain? So that is completing Socrates or completing Udibara. That will be the first step. Invest as much as you can in the first step, because investing more in presenting complaint gives you a typical diagnosis and rules out every other differential. But if you do it quickly, you will lose your right diagnosis. That will be the first step in every presenting complaint. Second step in the presenting complaint is asking about trigger. Trigger is always a healthy question. Why? Because trigger can usually guide you to a perfect risk factor or a perfect diagnosis. For example, Anna, was that headache triggered by anything at all? Yes, doctor, I failed the Lab 2 5 weeks ago. So what is that? That is tension headache then. Anna, was that triggered by anything at all? Yes, doctor, I moved to a new home and we had a new heater fitted or a new maintenance work at my home, and everyone at home has similar symptoms. What is that? That is carbon monoxide headache. Let's have another one. Anna, was that triggered by anything at all? Yes, doctor, I was drinking too much alcohol last night. My team has won a game and then I wake up with that headache. That is hangover headache then. So trigger is always a healthy question, and you will find it in every single mind map. So please remember to ask about trigger. And then the last step in the presenting complaint, that is we ask about other, and the other usually are 2 others or 3 others. Okay, I'll tell you what are these here. The first other is an open question again to tell the patient if he has any other symptoms. The best one to help you in the consultation is your patient. So Mr. Jack, apart from the headache, do you have any other symptoms at all? Yes, doctor, I feel nausea, I feel sick. That is a common association of migraine, headache, and sickness. Okay, Mr. Jack, with that coughing, do you have any other symptoms at all? Yes, doctor, I have spiking temperature. That may be an infection then, or pneumonia. So ask other to the patient to help you, okay, as an open question here. That is the first other. Second other is for you as a doctor, okay, which is other symptoms of the same system. If someone coming with a chest symptom, you need to ask about other symptoms of that system. Why? You need to understand the concept. Why? Because the most close differential to any chest problem is basically other chest problems. So if he's coming with cough, I will ask him, Mr. Jack, apart from the cough, have you been experiencing any chest pain at all? Any difficulty of breathing? Any heart racing? I will complete other symptoms of the same system. Yeah. If he's coming with, for example, vomiting, I will complete other GIT symptoms. With that, do you have any tummy pain at all? Any bloating? Any problem with your bowel habits? Any constipation, diarrhea, bleeding from the back passage? That will be the second other, as clear as that. And then the third other, in some cases, if that organ has a double organ, if we have, for example, 2 eyes, two maybe two eyes, okay, maybe two arms or few joints. So you can ask about how about the other eye, how about the other breast, do you have any other do you have similar symptoms in the other breast at all, how about do you have similar symptoms in other joints at all. So when the organ has different sides or different places, you can ask about other related sides as well. That would be the first step in every consultation, and believe me, if you focus on that step quite carefully, you will get your right diagnosis straight away, and do that order, it will be magic to give you the right diagnosis here. Then second step is closed-ended question, and you need to understand the concept of closed-ended question. Why did I tell you in the first step to ask an open question, and now I'm telling you shift to close the questions? You need to understand the concept of that. The concept that the first part of consultation, the first 1 or 2 minutes, it is the patient part. I am empowering my patient to give me a perfect story. I don't know anything yet. I need to listen to his perfect story of migraine or tension headache or myocardial infarction to understand that case. And then after he gave me that perfect story, now it is my time as a doctor to lead the consultation. That is the doctor part. So the doctor part will be focused, relevant, closed-ended questions, means yes or no questions to wrap that story, to close that story on that perfect diagnosis here. So that is closed-ended question, yes or no questions, to talk about two things mainly: red flags, which can kill the patient today, what can be serious today, and the main differentials. Not all differentials, it's only 1 or 2 maximum differential of the most close differential to that story. So let's imagine that is a case of headache. What would be the red flag for me in case of headache? Maybe tumor, brain tumor, someone coming with headache for some time. So I will ask about Mr. Jack, yes or no questions, guys. Yeah. With that headache, have you been experiencing any weakness in your arms or limbs or face at all? No, doctor. Yeah. Any problem with balance, any problem with speech, any problem with vision? One question at a time, and ask maybe 1 or 2. He will say no. That would be my closed-ended question for the red flag. For example, someone with vomiting, I may worry about dehydration, so you can ask about Mr. Jack, have you been getting dizziness with that at all? Okay. Maybe you are worried in ectopic pregnancy about rupture, any shoulder tip pain at all, any dizziness or any fainting feeling at all. So that is closed-ended question for red flag. The second step in closed-ended question is for asking about the main closed differentials. And in every case, I'll tell you what is the main relative differential to that case. But to be honest with you guys, if you do that step quite complete, as I told you, with the red flag which can kill the patient today, usually you do not need much differentials, or even though sometimes you do not need any other differentials because it's a typical story. So we'll know that with each case, of course, just to know the concept so we can be clear on that. The third step is called the general well-being of the patient, and you need to understand as well the concept of that step. You call it maftosa. I don't mind the word maftosa, but for me to accept maftosa, I need to call it relevant maftosa. Because if you ask maftosa as a random set of questions or as routine questions, you will go to hell. That is rubbish. Okay. For example, someone coming with conjunctivitis, and you ask him past medical history of high blood pressure. Why? I don't know. Past medical history of I don't know, chlamydia, and someone coming with headache. Why? Okay, so you need to be relevant to the story. That's why I call it general well-being of the patient. And again, what is the concept of that step? I told you that is the patient step. That is the doctor leading the consultation. That step is for the risk factor. I need to know how this patient was doing before coming to me today. How was his general health, so I understand what conditions he may be at risk of getting or developing. Yeah. That is the key point of that step, is understanding the risk factor in the patient general health. That includes the past medical history of anything relevant to your story. For example, if someone coming with a chest pain, so then maybe you can ask about any past medical, have you been diagnosed with any long-term medical problems at all, any problems with your lungs or hearts at all. And then medication, you can ask about, are you taking any medicines at all on regular basis. And when you ask about medicine, usually medicine can include 2 important things here: medicines that he may have tried for that problem, or medicines he is taking on a regular basis for medical problems here. For example, if he's coming with headache, when you ask about medicine, Mr. Jack, have you tried anything to help with that headache at all? Why? Because that is relevant information for me to know, and I can use it in my management to give him something different or to reflect on that. And then, Mr. Jack, are you taking any medicine on a regular basis at all? Yes or no? And then you can ask about allergies. You can skip that question many times, but you can ask about it whenever you think you will likely give a medicine today. But anyway, you can ask, Mr. Jack, do you have any allergies to any medicines at all? Yes or no, doctor? If it was a lady, you can remember to ask about bees. What is bees in lady? We have 4 bees in ladies. I don't like to ask them in every case, of course, but I'll tell you when they are relevant. Yeah. First B for pregnancy, second B is for period, third B for pill, and force P for pap smear. Okay, you don't need to ask them in every single case, but you need to remember one rule only. When you have a lady in the childbearing period, young lady, you always need to make sure if she has a chance of being pregnant or not, because any management you give may change if she's pregnant. For example, if she has migraine and she's pregnant, you may change your management. You may give some medicine above each others, okay, because some of them can be teratogenic, some of them can be fine. So always, if it's a lady in the childbearing period, just remember to ask one simple question: any chance you may be pregnant at all? No, doctor. Yeah. Okay, otherwise the 4 B's will be very relevant in gynae cases. For example, when was the last menstrual period? Any chance you may be pregnant at all? Are you up to date with pap smears? Are you using any contraceptions at all? That will be nice and relevant in gynae cases. However, in any other case, if it's a lady in a childbearing period, always remember to ask about any chance she may be pregnant, because that can affect the choice of medicine you are giving in the management. And then family history of similar symptoms or family history of risk factor. For example, if someone coming with hypertension, okay, I'm diagnosing hypertension, so then anyone in the family has been diagnosed with high blood pressure. If someone coming with a chest pain, anyone in the family has been diagnosed with heart related issues or lung related issues or blood clots, for example. So you will make it relevant to the story. That is your job in that step. Maftosa is good, but make it relevant to your story. If someone coming with ear symptoms, so ask about any family history of ear related problems at all. And as well, the second thing in family that you can remember, family as a contact. For example, if someone coming with vomiting or fever or cough, you can ask about anyone in the family has similar symptoms at all, because some medical problems are contagious, okay, or maybe infective, some people infecting each other. And then the last thing in Maftosa is the lifestyle questions or the life habits questions. Do you smoke at all? And if yes, you will ask how much and for how long. Alcohol, do you drink alcohol? Yes, doctor. So how much do you drink and for how long? And then diet and exercise. Some people call it DESA. I don't mind as well, but I mind if you ask it in every single case. It may not be relevant at all in some cases. Only ask about it when it is relevant. For example, I will give you a question. If that case, someone coming with coughing of blood, what will be relevant here? Diet? No, don't ask about diet at all, okay? But ask about smoking, because it's a risk factor for lung cancer. If someone coming, for example, with ascites in the liver and ascites and maybe hepatomegaly, okay, or maybe vomiting of blood, what would be relevant? Of course, alcohol. That can be varices or maybe liver damage. So is it then activity? No. So you will choose what is relevant to your case. For example, someone coming with dyspepsia or heartburn, then all lifestyle are important because all are risk factors. Yeah. So what I mean in that step, DESA or diet, exercise, alcohol, smoking, they are good to be asked when they are a risk factor. But if they are not a risk factor, don't spend too much time on them. If it's a chlamydia case or gonorrhea case, why would you ask about diet and chlamydia? It doesn't make sense, okay? You can ask about smoking, it doesn't matter. But just to be selective, what is my point here is that, okay? So then psychosocial, ask psychosocial please. And psychosocial is not optional. I always say psychosocial and ICE are mandatory as much as you can. If the patient is able to talk to you and you are taking history, psychosocial and ICE will be always needed. Yeah. Why? You need to understand the concept as well. Psychosocial means how this problem has affected that patient, and you need to understand that is the first main reason he came today. Because for example, you have headache and I have headache now, but we didn't see a doctor. Why? Because it didn't stop us from studying or from meeting together. Okay, so it didn't affect me yet, or it didn't affect you yet. That's why you didn't go to see a doctor yet. But when the patient comes to you, comes to see a doctor, then the problem has affected his life. That's why you need to ask psychosocial, and I always call psychosocial impact on life. Mr. Jack, how that has been affecting you? Has that stopped you from doing anything you used to do? That would be the aim of psychosocial. And any problem medically or mentally can affect the patient life, usually at home and at work. So you may tell your doctor, I couldn't go to work, or it's making me feel I'm not able to look after myself, after my kids, after my family, blah blah blah. Some cases when the symptom is going for a long time, such as chronic fatigue syndrome, maybe acne, some problems that is happening for a long time, it can even affect the patient life to the extent that it affects their mental health. Okay, for example, hypothyroidism, tiredness for a long time. One of the symptoms of hypothyroidism is actually depression, because it can affect the patient mood. Mr. Jack, how that has been affecting you? Doctor, I have been feeling low because of that. If the patient gives you a clue that this problem has been happening for a long time and it starts to affect his mental health, then screen for depression. And you know my 2 questions for screening for depression. So Mr. Jack, would you say in the last months you have been feeling low or depressed? Yes, doctor. Mr. Jack, would you say that in the last months you have been losing interest in things you used to do? That is the 2 screening questions for depression. You will have that later in details in the psychiatry, but that can be part of my data gathering if I feel the patient is going through hard time or getting low because of the long duration of symptoms here. Okay, and then you can finish your data gathering by asking ICE, idea, concern, and expectations here. Okay, why this one as well? I say it's mostly mandatory in most cases because you need to understand what is the second reason for the patient to come to see a doctor. First reason, that it affected his life. The second reason, that he may have some ideas about it. Yeah, he may be coming to you today because he thinks this cough is a lung cancer. He may be thinking this headache is a brain tumor. So if you do not understand to explore that concern or that idea, you will fail the station because you failed to know the issue. You failed to know the cause of his visit today. Okay, so Mr. Jack, what do you think may be causing that for you? Anything in particular is worrying you about that headache? Were you hoping for anything specific I can offer you today? Or have you given any thoughts? How can I help you today? There is a lot of ideas or a lot of phrases for ICE. You can see lots of them in the IBS mechanics session. Just have a favorite one for yourself and use it all the time. Okay, so ICE is important. The second key about ICE, don't be robotic. For example, if the patient is telling you in the beginning of consultation, I would like to have a prostate specific antigen, or I would like to have a prostate blood test, you cannot ask him in the end, what is your expectation? Because he already gave it to you. If the patient is coming for the consultation, says, doctor, I am worried about brain tumor, and he starts like that, okay, or I am worried about blah blah blah, then you cannot ask about concern later because he gave it to you. So ICE is relevant, but make sure you do not repeat what is given. If he gave you some part of ICE, don't repeat it again. You can acknowledge it, okay, that's fine, but you don't need to repeat it one more time. And if you repeat it, you need to sound natural. Mr. Jack, I'm aware you have been worried about prostate cancer. Anything else in particular you may be worried about as well? That would be acceptable because you reflect that you have listened here. Apart from that, don't repeat if it was given to you part of ICE, just to do what is missing, as simple as that. That will be the data gathering in every single case, guys. And then we finish data gathering by offering examination, and that is relevant examination. Yeah, in examination there are 2 advices, 2 key points here. The first one, it should be relevant examination. Do not ever say head to toe or general physical examination, because that is rubbish. We don't have any head to toe in lab 2. Because what is head to toe? Does that include the little toe or not? Does that include the back passage or not? I'm not sure. Okay, so don't say head to toe, because that is very cheap and very rubbish. You need to specify what you are looking for. For example, someone coming with a chest pain, I would like to examine you, Mr. Jack. That will include me checking your blood pressure, your heart rate, your oxygen in the blood, and I will be examining your lungs and your hearts and your legs as well. I need to specify what I'm looking for, the organ I'm targeting or the related organ to that problem. Yeah. That is the first thing, not to be general and be specific. Yeah. The second advice about examination, you should never use medical jargons. So don't say to the patient, I will do cardiovascular examination. Go to hell. What is cardiovascular to the patient? That's a medical jargon. He's not your colleague. He's a patient. He's a normal person. So you need to say things in a simple language, okay? For example, in vertigo case, don't say, I will Dexhal bike you. What is Dexhal bike you? He will get worried about that, okay? So you need to tell him, Mr. Jack, I would like to examine you. That will include me doing a maneuver or some exercise with your head and the neck movement to help me understand the cause of your disease pulse. That is called the Dexhal bike. Then it will be acceptable. Yes, you mentioned the jargon, but you explained it in a simple language. So the key in examination is 2 things: be simple and be relevant. Yeah. Then after examination, we start our management here. So data gathering ends here and the management starts there. Okay, so management starts by giving a diagnosis. The key advice, you should always keep 3 minutes for management. If you manage any case in less than 3 minutes, please consider that is a failing case. End of the story. Take that as a religious rule. If you practice from now on the package management in less than 3 minutes, you are a good example of someone trying to struggle with BLAB 2. You are a good example of someone who is likely to fail BLAB 2. End of the story. 3 minutes at least. Why? Because there is a lot of meat in management. There are 4 markers for management. There are 4 markers for interpersonal skills, which actually most of them in management, because there is no magic in taking history. There is no magic in data gathering. Everyone can ask questions. Everyone can take data gathering, but not everyone will be able to manage the patient, address his concern, and talk to a reluctant patient, blah, blah, blah. So management starts with diagnosis here. what you need to know, that diagnosis in BLAB 2 is usually clinical diagnosis and usually is suspected diagnosis. So there is a common confusion. Do I need to offer investigations first or diagnosis first? No, diagnosis comes first in the right consultation structure, because after you listened to the story, after you did a relevant examination, now you have a suspected thing in your mind. That is what we need in diagnosis. Yeah. So you start that by saying, having listened to you, Mr. Jack, having examined you, I think what you are experiencing is a migraine type headache. That is how you start your management and diagnosis. Yeah. So start by sharing your thoughts. After that, you can engage the patient by asking him, have you heard about that before? Or do you know what is migraine? That is the second step in diagnosis. Yeah. The third step in diagnosis is actually explaining it in a simple language. Even if he knows about it, you still need to explain it in a simple language so you both understand the same way. So Mr. Jack, migraine is a one-sided headache that takes you to bed. Am I making sense? Okay. And then you check understanding by saying, am I making sense, or is that clear to you? Okay, that is diagnosis, guys. Suspected, you should start by sharing your thoughts and then check if the patient is aware of something like that, and then explain it in a simple language and check his understanding. Am I making sense, for example? Yeah, that will be the big part of your start in management, or the main start for the management. And then investigations can be offered as part of management when it is relevant only. Do not offer it in every case, because that is rubbish. That is waste of NHS resources. That is waste of our taxes. For example, if someone coming with migraine or sore throat, okay, or maybe like common cold, why would you do investigations for migraine? What are you looking for? Dr. House, what are you looking for? Someone coming with one-sided headache, throbbing in one side, gets worse with flashes of light and with noises, and gets better with lying down in a dark room. What else do you need to know? It's migraine. So don't do investigations on migraine. Don't do investigations in simple cases as well. Only offer it when it is relevant to the story only. Okay, so when it is relevant, I will tell you in every mind map, of course, but most of the cases usually we wouldn't need investigations. So management, I will start by diagnosis and moving on to manage the patient. The first step in management, after giving the diagnosis, I will always advise you to kill the elephant first. So what is the elephant? The elephant is the big elephant in the room, is actually the concern of the patient. I told you concern is very important. So let's imagine that is a case of headache and the patient told me in data gathering, I am worried that brain tumor can be causing that. Then after I gave my diagnosis, I would usually start by killing the elephant first, because that is the issue in consultation. And if I kill it first, I make my patient reassured, and then I can take a deep breath and manage him, and that will be the safest way to do it. Okay, so Mr. Jack, I'm aware you have been worried about brain tumor being the cause of your headache. I'm happy to reassure you it's very unlikely, because usually brain tumor presents with different symptoms such as problems with vision or problems with balance. As simple as that, guys. Yeah. So please give diagnosis in a simple language, and then as soon as you can, kill the elephant so you can actually move forward. Yeah. And then the second step, or the following step in management after killing the elephant, always aim to make your management patient-centered. Patient-centered means if you addressed his concern, that is actually patient-centered, because you brought his concern and you addressed it, so you made it patient-related story. And second thing, how to make it share the management plan. There is a key golden line I always like to use, which is the word options. When you tell the patient there are few options we can do to help you with that, usually the word options itself gives the patient the comfort that it's not only one thing I need to do. There are a few things we can consider, or we can take one or two of them. So always use the word, there are a few options we can help you with that. Or you can say, for example, Mr. Jack, for us to help you with that, there are a couple of things you can do and a couple of things we can offer you as well. Things you can do, then you can talk about lifestyle changes, guys, or things which he does at home to help, and things we can do, maybe giving a medicine or maybe referring or blah blah blah. Okay, the key point as well in that management, that with every chunk of information, so with every bulk of information, check the patient understanding. Have a pause and ask him, Mr. Jack, am I making sense to you? Okay, is that clear? Do you want me to repeat that again? So always a check understanding. Yeah. And then continue the management with the specific management you have for that case. That can sometimes include adjusting the risk factor, advising about the lifestyle, but the aim always for management is three things: starting with diagnosis and explaining it in a simple language, then bringing the big elephant and killing it, and then saying about options. There are a few options we can help you with, like blah 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 blah. Okay, that would be the key 3 points you need to focus in the start of your management. Yeah, that will make it a clear cut 4 out of 4. And then once you finish your management, you will always finish by 3 things as much as you can: follow up when it is relevant, safety netting, and the leaflet. Yeah. So let's talk about follow-up. What is follow-up? Usually follow-up is advisable, but you don't need to use it for granted. Don't use it in every single case. For example, if someone coming with tonsillitis and it's a viral tonsillitis, everything is quite safe, he is not doing unwell, okay? So what you can do, you can make it relevant. For example, you can say, Mr. Jack or Mr. Smith, if you don't get better, please call us back for a follow-up. As simple as that. That is actually safety netting and follow-up in a simple line. If you don't, or if your symptoms are getting worse, please do call us back for a review appointment. Yeah, as simple as that. But some cases you must offer follow-up. For example, if you are starting antidepressant for someone, sertraline for depression, okay, you must follow up. The guideline is telling you if you start medicine for depression, you need to follow up in a week time if the patient is young, because they are at risk of committing suicide, for example. Okay, so if the patient is younger than 30 years of age and you are starting antidepressant, you follow up in a week time. If the patient is older than 30 and you are giving antidepressants, so please follow up in 2 weeks time. But again, you do not need to go with the weeks as a strict rule. If you say 10 days, it will be fine in both of them, so don't worry. But offering follow-up is needed in that particular case, of course. For example, if you treat a patient with chronic problem, hypertension, for example, and you are starting amlodipine or ramipril, you need to mention follow-up. Mr. Jack would like to follow you up again in a couple of weeks time, so we can check your blood pressure diary to make sure the medicine is working, and as well we can do a blood test to check the kidney function, or to check that your blood your medicine is not causing any harm to your kidneys at all, something like that. So what I mean in follow-up, it should be relevant and sensible to the case. Safety netting and the leaflet, always aim to offer a leaflet. And again, there is a big drama about leaflets. Some people will say, doctor, should we offer a leaflet only if we have it on the table? You will never have it on the table, guys, okay? You will never have it on the table. Leaflet in UK is the concept of sharing information, the concept of signposting to a source of reliable information. So for example, you can tell the patient, Mr. Jack, I will print a leaflet for you about that, so you can read more about it. If you have any questions, you can always call us back for a discussion. So you can actually print it for him in the real consultation in real life, or you can say, I will send it to you in a message, because in UK we have a system where we can text patients with anything we need to do or any updates we need to tell them. So Mr. Jack, I'll text you as well with a leaflet about information about that migraine, so you can read more about it. Yeah, so easy busy. So offer leaflets about the medical problem itself in every case whenever you can. And then safety netting of what? Of red flags, guys. So what I was worried about here, if I'm sending the patient home, I will safety net about here at the end. For example, if someone coming with, let's say, sore throat or problem with the mouth or problem with the throat area, what would be the red flag for me if it's affecting breathing or feeding? So Mr. Jack, if your symptoms are getting worse, or if it's affecting how you swallow or how you breathe, please do seek medical advice again, or do call us back for a review, please. So something like that will be very sensible. Yeah. So guys, that is the general structure for every single case. Sorry for being long, sorry for being quick as well, but you need to understand the concept of the structure, because you need to believe in the structure. You need to know the relevance of every step, so when you do it one time after one time after one time, it will follow subconsciously. After a few weeks from now, maybe 2-3 weeks of doing the same structure in every single case, you will find every mind map following the same structure. You should have it subconsciously in your mind, and you never think about your questions, because it should follow subconsciously. You do them in every single case every day until your exam day. So then what happens? You will listen to your patient. You will have good active listening skills, because you do not think about your next question. It flows naturally. And that is the key of having a master key structure. Please get 12, and I will see you next.